Okay, I did want to just kind of bring us back together with this slide, just pointing out all of the similarities between Oregon's PCBH care, core attributes and the primary care behavioral health goals. So maybe some of you are pursuing that track, some not, but you can see how similar they are, starting with access, accountability, measuring quality of life at all visits, measuring helpfulness at all visits, and suggesting very specific measures of fidelity to the model that Kirk will cover briefly at the end of this afternoon. This afternoon you will learn about the Duke Health Profile and those scores that can be used in terms of measuring comprehensive whole person care. You can certainly measure continuity in terms of BHC availability throughout the lifespan to patients, as I was kind of hinting at this morning before lunch. Coordination and integration, I think that this model of care can help you a great deal with reducing ER visits and unnecessary hospitalizations. I just came from a conference in Denver yesterday where Kaiser was presenting on how they were using their behavioral health consultants with to save, I think it was a phenomenal number. It was like $4 million on 60 patients using behavioral health consultants. And some of the examples, behavioral health consultants would say, yeah, I could do that. I could do that. Person and family-centered care. So the BHC is definitely providing services to individuals, couples, and families. These are not just individual visits. Okay, so now I want to introduce you to your primary care behavioral health toolkit, and that is the black binder there in front of you. And if you just open it up, the first tab is the program manual. You'll get all of the materials in this black book on a thumb drive, so you can modify it. You can just search for your clinic and put in your clinic's name. And then you've got a beginning template for a program manual for your program. And then you can read through it with a group from your clinic and make decisions about things that you may want to modify in order for it to work best for your clinic and your resources at this point in time. If you turn to that second page, you'll see the table of contents. On the digital version, you'll be able to, like, if you want to, for example, Roman numeral 4, roles and responsibilities. If you wanted to know about the roles and responsibilities of people on the PCBH team, you would just click, and it takes you there. So it's a very user-friendly format, and one that I think will be quite helpful in terms of moving your program along, really creating a strong foundation. And like one of the questions I had at lunch when I was talking with the behavioral health providers is, well, what about, if I'm a whatever licensed as a psychologist or as a social worker, and don't I have to do a comprehensive evaluation like I've been doing in mental health? And so we were talking about the importance of a manual that specifies the policies and procedures of this program. And I said, if you have that and you're following it, you're in trouble if you're not following it and you're following mental health. But you need this. You need this structure to define your roles and responsibilities and the procedures and quality standards that pertain to your work as a behavioral health consultant in the primary care behavioral health model. So the manual includes vision, mission, guidelines, goals, objectives, of course, the roles and responsibilities. And this is not just of the behavioral health consultant, but also the assistant, the facilitator, the primary care clinician, the nurse, and the MA. And they're all spelled out there for you all to think about and look at over time. There's also a training program overview. And then in the section on clinical activities, it explains exactly what the services are, the brief intervention services that I mentioned this morning, the pathway services, and it spells out excluded services, things like legally mandated kinds of evaluations, and psychotherapy of any kind. We're not really psychotherapists, we're consultants focused on behavior change. The manual also includes a variety of practice support tools that are useful to PCCs, BHCs, and nurses and MAs. And we're going to use a couple of them this afternoon to get you going. There are things like scripts for RNs and PCCs to use in referring. We were talking about, wow, that's the hardest part, often, is getting the patient to yes. There's a lot of outcome assessment tools and screeners, and policies and procedures related to patient access, informed consent, and clinical assessment standards. There are charting, documentation, peer review tools for initial visits and follow-up visits. They're quite brief and practical and easy to use, but do assure quality. Some guidelines for providing feedback to PCCs, some information about medication consultations, psychiatric consults, administrative procedures, including a template for BHC appointments, revenue billing kinds of, there's a section for that as you all become wise. And you can fill that one in. And a suggestion of performance measures, including staffing guidelines and productivity standards for the BHC, which in this model is 10 completed per day. Also, core competency tools for all members of the team to use in assessing their skill level. There's a lot of manual appendices, and they start in tab 2 and go all the way back to tab 12. They are in the header, they're listed as ABC. The tabs are 1, 2, 3, so I'll mention 1, 2, 3, and ABC when we refer to this. So it's a lot to look at, and we can't hope to go through all of these today. The idea is only to introduce you, but the behavioral health consultants going through training in days 2 through 4 will have a chance to look at all of these materials and be familiar with them and be able to go back to the clinic and kind of share this in small amounts with other members of the team. Of particular interest in Appendix G, for example, tab 8, just give you a chance to look things up. Look in tab 8. And you'll see a list of assessment outcome tools that are very useful in the PCBH model for a variety of problems ranging from domestic violence, anxiety, depression, ADHD, cognitive impairment, substance abuse, pain, and overall health. So for each of these, as indicated screeners, if you turn to the next page, you'll see there's a quick guide that describes the target population, the languages that the tool is available in, how to use the screener or tool, how to score it, a little bit of information too in terms of recommended uses. So all of that's there for you, And I think where I would have you turn now is to tab 9. We're back there. To the patient brochure. We recommend that you develop a brochure for your clinic that explains what primary care behavioral health services are. Okay? As you move towards this model, the first thing you need is a tool that describes what it is you're doing. You can use it in many venues. The behavioral health consultant can take it out to community partners and say, we have primary care behavioral health services at our clinic, wanted you to know about them. You can put it in your waiting rooms. You can put it in exam rooms where PCCs can pick it up and say, hey, I'd like you to see so-and-so, our behavioral health consultant. This describes our services here. And use it as part of the warm handoff. Certainly if the patient doesn't have a copy of this brochure by the time of their first visit with the behavioral health consultant, then it's important that the behavioral health consultant give it as part of their introduction. So to simply say, hi, I'm so-and-so, I'd like to tell you a little bit about myself and my role here at the clinic. This is a brochure that describes our program or our services. Mm-hmm.
You mentioned that psychotherapy wasn't part of the model.
Right.
So we have a clinic that we use psychotherapy, outpatient psychotherapy. How would that work in this? I mean, like,
Well, I don't want to
you can
sound...
address, like how you determine which is a behavioral health consultant and which would be psychotherapy?
Yeah. If you're working as a psychotherapy, it's a different kind of job, usually. And you would tell patients, you would be required to tell them that you're providing psychotherapy and kind of the risk and benefits of that. When you're working in primary care, that doesn't apply. You're working as a consultant. You're part of a team. Now, you may use some psychotherapeutic interventions that have an evidence base, but they're adapted to the consultant role and to the constraints of, constraints and benefits, I would say, of your practice context.
Would you suggest having both?
It depends on the ability of your users to pay. Most people, psychotherapy is a pretty expensive service for most people. It's expensive in terms of money, it's expensive in terms of time. So when you look at your population at your clinic, you say, yes, we have a significant number of people coming to us that would like to spend an hour with somebody and that have the money to pay for that, then why not? Because it's patient-centric. Now, that being said, we don't have any evidence that indicates that spending an hour with a patient providing a psychotherapeutic intervention is more effective than spending 30 minutes.
What about like trauma exposure therapy? How would you do that in 30 minutes?
Well, there's a protocol that has already been tested and is just about ready for dissemination in the United States Air Force. It's more of a cognitive processing therapy narrative kind of approach combined with problem solving, but it's 5 30-minute visits, and they're getting really good results. And not only that, but the people it doesn't work for, they're getting better engagement when they refer to specialty mental health.
So some of the people that were at my table have the behavioral health consultant certificate. So is that needed along with this, or that's just kind of an added bonus for your own personal education? What are your thoughts on that?
I think that the most important thing for you to obtain as a behavioral health consultant is a core competency evaluation that indicates you're at least adequate in all areas of practice. So that's a pretty high standard. That means not just kind of self-assessing, you think you know, but having somebody watch you using a standard tool that says these are the competencies associated with this job, and seeing someone experienced and saying, yep, you're there. This is a little low, work on that. Or you're really good at this. Why don't you tell other people how to do it? Be sure and show them. Yeah. But anything short of being really thorough is a problem when we're going for a radical change like this, because if you're not thorough, if you don't pay attention to all areas of your practice, when you get out there alone, and many of you will be alone in your clinics, you're not going to have other behavioral health consultants that watch you all the time. And you're going to get under pressure, and what do all of us do when we're under pressure? We go back to what we knew how to do. And suddenly you're kind of doing a little of this and a little of that. So it's a little bit uncomfortable, the thought of having people watch you, but in this model of care and by the organizations that are getting the best results, that's been the training model. There's a lot of watching. Oftentimes a lot more watching and coaching in real life practice than we got in graduate school, actually. So, good question. But it's good to have any kind of certificate. You know, it's awesome. I don't know which one you went to, but people find, you know.
I got it from them over there, just the idea of getting it.
It was Fairleigh Dickinson out of New
Oh,
Jersey.
that's a wonderful program, yes. I'm on their faculty.
Yeah, I know.
Yeah.
There you go.
Oh, good. Yeah, the certificates are good. Sandy Blount's program is good too. It's just kind of the highest standard is to be watched and to watch each other, you know. But yeah, that's nothing to sneeze at, that certificate. That's awesome. Good for y'all. One of my favorites, Naftali and all those guys. I think this brochure is written in a way that really minimizes stigma. The reading grade level's about 5th grade, and it really addresses a multitude of kinds of problems that people have in their lives, whatever the age, but you know, from children to preparing for the end of life. I mean, people have these problems, and it introduces the concept of working with a team, which we must start to prepare our patients for working with a team and being a member of that team. So, good. Any other comments from patient perspective? Yes?
You know, really reading it from a patient perspective, one of the thoughts that came to my mind is, oh my goodness, look at all these people. What's it going to cost me?
Yeah, right.
I think, you know, just being aware that that may be a concern of some of our patients as we introduce this to them.
Absolutely. Patients will ask you, what's this going to cost? And, you know, when I was at Farmworkers, it was like, at first they were billing for me. Well, they said, you know, we don't know what we're doing. We're not billing. We just need somebody like you. And then they, you know, they were going to try to bill, you know, and then, so they tried that for a while, and then they said, you know, we're spending a lot more money billing for you than we are, you know, receiving in payments for you. And we've looked at it the other way in terms of cost savings, and we're not at all concerned about your salary. We'll pay for you. So tell them no cost. And that was a wonderful thing. So to be able to say there'll be no charge for this service kind of does remove the only barrier that people typically have. All right, well, very important, because this is your branding. This is the program. This is the way you get the word out to patients, to providers, to nurses, to MAs, to folks in the community. So put thought into developing this brochure. Personalize it. Make the pictures of folks that are like the folks at your clinic. And put any other, you know, information in there that you think would make it culturally right. So with that, I'm going to, oh, I did want to mention before moving on that in the last tab of your toolkit, and that would be tab 12, okay? There are patient education protocols. These are all evidence-based interventions for the most commonly seen problems in primary care by behavioral health consultant. So I want you to kind of look at that list, everybody, and that's under tab 12. So ADHD adherence, using meds successfully, but also just adherence to protocols or interventions, instructions. Alcohol, anxiety, chronic pain, depression, exercise, grief, headaches, hypertension. There's a 4-session parenting protocol. We can help kids a lot by being there to teach brief parenting interventions at the time of need. You know, we have fantastic, phenomenal parenting classes in our communities, but often they go unfilled or partially filled, and over again, even when we're doing them in the language of the people we're trying to reach, by the time we get to session 8, we've got maybe one family left in the class. So if we teach things like parenting in primary care, it's at the time the patient comes to the clinic, and we teach it in small bites and support it over time. So I really recommend that one. Sexual problems, sleep, insomnia, sleep is big, stress, substance abuse, weight management. All of these are protocols, and we have more things that we will cover over the week. And these are really nice. You can use them also sometimes as patient education handouts. You can personalize them. You'll have them on your thumb drive, so you can put your clinic's name on them. And I'm not a big fan of giving a bunch of paper to everybody, but these are a great way to train behavioral health providers and primary care clinicians and evidence-based interventions. And then some of them I would pass out to some patients. The competencies we would like to address just before our break are who to refer, so that if you're a PCC or you're a nurse, you can refer, you know who to refer, and then what to say when you're referring. Very, very important. To help you with these 2 areas, I'd like you to go to your manual, Appendices 7.
Is this in Toolkit you're talking about?
Yeah, in Toolkit, the black one, Toolkit, and it's the tab 7. Tab 7 has a number of things in it. What I'm going to have you look at right now are the first page and the second page. So the second page, let's look at that. It says PCBH program, referral form, all ages. This is just an example. You can modify it. If you're a pediatric clinic, you can change it up a little bit. You'll have it on your thumb drive. But it gives you a chance to look at the broad range of problems that the behavioral health consultant can address. And I like to say it's simple. There's no wrong referral. As a PCP or PCC, as an RN that's on the phone, talking to patients, doing triage, you don't have to decide, is this a right person or a wrong person for our BHC? Because one of the primary goals of an initial visit with a behavioral health consultant is to see if the patient can be managed in primary care. Now, what we find among different clinics is 90% of patients can be managed in primary care. So 9 out of 10 times, the patient will stick with the behavioral health consultant and be cared for only by their PCPC home team or primary care home team. But these are all of the things, everything from, what did we say? We saw sexually transmitted disease. I watched a visit on STD last week. Sexual health, we have huge opportunities to improve sexual health in primary care. Might not necessarily think of that. Headaches, hypertension, weight, of course. Well, child visits, just preventive kinds of education, stress of any kind, family problems, relationship problems, domestic violence, chronic pain, cognitive impairments, very broad range of things. On your visit, one of the things for you to do when you go back to your clinics is look at your visit check-in form, and you look at all of the things on that visit check-in form that involve making a behavior change, involve an intentional choice about a lifestyle behavior. Highlight those and talk to your MAs and say, when you check the patient in, if you see any of these, alert me. We may want to get the BHC involved. Okay? Takes the pressure off you to always being the one to identify. Of course, pathways also take that pressure off the PCC and the RN. So that's who to refer. And now to how to refer. Just flip back one page and you'll see some suggestions there. 1, 2, and 3. And things to emphasize. I just was walking around listening to conversations. It's awesome, you know, how you're thinking through things and anticipating. And one of the things I heard you anticipating is when patients are kind of ambivalent. You make your pitch and they look down and say, oh, not today or whatever. So I was hearing some creative things like, well, give them a brochure. And make a note in the chart that when they come back, I'm going to ask them again. Another thing that you can do is kind of that meet and greet kind of option, where you can say, hey, I just want you to meet Patty before you leave today, just so you have a face and you can make up your mind if you want to see her or not. Because if you get me or your BHC in the room, and they just say a few things, it's kind of different, you know, for the patient. It's a different experience, and they may say, hey, you know what, I'll make time. So when they are kind of ambivalent, think that through, and remember, all you got to do is send your MA down the hall to knock on the door, or you can knock on the door. If the BHC is with someone, they'll come out and do that meet and greet. Only takes them 2 or 3 minutes, and that patient is more likely to get service. So think of that when you run into that ambivalent person. And do remember when you are referring to say she probably can see you the same day, because that really helps people say yes. It's like, really? Oh my gosh, I didn't know y'all had something like that. Because we know it's psychosocial distress to some extent. Every time anybody comes to a primary care clinic, if they didn't have some psychosocial distress, they might be able to get by with whatever it is that's ailing them or hurting them. Probably 9 out of 10 times. The other thing I wanted to mention is thinking through from an operations point of view, and time, efficiency, thinking through how is the referral made? How is the system set up so that referral is easy? So we ideally don't have any kind of system that requires filling out a form, really. I showed you an example referral form, but that's just to, well, we've got a couple of things that helps with, like helping the PCC remember to refer a broad range of patients, making it easy for the PCC to target a problem and to kind of negotiate that with the patient, so it's not like, I don't know what's wrong, fix them, because that sets the BHC up for a, you know, kind of like, what is this, a mental health evaluation? No, it's really part of the PCC's responsibility to negotiate a target problem for the visit with the behavioral health consultant. how to refer any way that's easy. So more and more we have programs like Office Communicator that has instant messaging. So the EMA or the PCC can simply put in a referral problem and room number, and that pops up on the computer screen of the BHC with a tone, and that BHC is immediately saying, I'm on my way, if they're not busy, and they go down and get the patient. If they're busy, they say, send to waiting room, 10 minutes. So it's telling the patient just to wait 10 minutes in the waiting room, and the BHC will go and get them. So that saves any kind of step, overcomes barriers. If PEDS is down 2 hallways, they can still reach you as if you were next to them. Also, texting. Kirk uses texting in his clinic, so all the EMAs text him the information, he texts back. Some clinics it's page overhead, some clinics it's knock on the door is the more routine sort of thing. No wrong way. We want to have multiple ways that require as little effort as possible, and encouraging that same day rather than a future. But you need to figure out, for those people that say, can't do it today, I got to pick my kid up, you got to look at those, what's that patient going to experience when they go to schedule that appointment? Does the front desk know what to do? If there's an appointment line, they're going to call to get that appointment line. Does the appointment line know what a BHC does, what their name is, what kind of appointment type to put that in so it can be tracked? Lots of operational details in that kind of transfer.